The classical staging system is this one here, as you mentioned before, about stage 3. So stage 1 is where it's one area. Stage 2 is where it's two areas, but confined to the same side of the diaphragm. Most of the time that will be above the diaphragm because most types of lymphomas do involve the chest and upwards. Occasionally it could just be in the abdomen. Stage 3 is where it is on both sides of the diaphragm, and then stage 4 is where essentially the disease has spread to areas outside the lymph glands. That might be the bone marrow, it might be the brain, it might be the bones. In men it might be the testicles, for example, which is another spot that it can involve. We tend to stick letters on the end of the staging system, so if you've got B symptoms, which are fevers, sweats or weight loss, you would then be, say, stage 2AB. If you don't, you're stage 2B. If you don't have those symptoms, you're stage 2A. We whack an E on if there's just one site of disease outside the lymph nodes, and S if the spleen is involved. So if you've ever looked at your thing and you see that the doctor said you were stage 2AE or something like that, that's the reason behind that. The main ways that we stage people, CT scans, been around for a long time. Could MRIs replace them? Perhaps in the future. MRIs have an advantage in that there's no radiation exposure. They have a disadvantage in that they're still relatively uncommon in Australia and there's still an out-of-pocket expense. And if anything, the lymph glands aren't visualised quite as nicely on an MRI scan. The MRI people tell us it's just because we're not used to looking at them, but whereas we've obviously been looking at CTs for many, many years. But at the moment, CTs are very accurate. They can be added to using a PET scan, and I'll show some pictures of a PET scan. And the final thing, unfortunately, is a bone marrow test. As I said, different types of lymphomas have a certain predilection for getting into the bone marrow. Hodgkin's rarely involves the bone marrow. The low-grade lymphomas typically do involve the bone marrow, whereas the more aggressive ones often don't. We collect them from the back of the hip because it's the easiest and safest place to collect the sample from. There's no other important structures overlying the hip bone. Back in the old days, you know, we used to unfortunately have to take them from the sternum. We rarely have to do those now. This is what a normal bone marrow biopsy looks like. So all these white things are actually fat globules. So our bone marrow is full of fat. And this is, over here, this is normal bone marrow, whereas you can see there seems to be an increase in the number of black nuclei cells adjacent to the bone over here. That's actually involvement with lymphoma. Lymphomas, for some reason, have a propensity, when they involve the bone marrow, they tend to abut the bone. So we don't tend to see them over here amongst the fat space. X-rays can be the first way that a lymphoma gets diagnosed. Somebody might go along to their GP and complain about a cough that hasn't gone away with antibiotics. This is an example of a young girl who had a mediastinal mass, and it's very hard to see, but in fact, basically the mass is sort of behind the breastbone there. And again, it doesn't project very well, but this here is a mass. So this again was, you know, done by a GP or a hospital emergency department, somebody coming along with a cough, and it's found out they've actually got a mass behind the breastbone. This is a CT scan, so it's a cross-section through the upper part of the chest. This is what a normal armpit looks like on a CT scan, so it's basically black space, whereas when you come across here, there's 2 or 3 large lymph glands in the left armpit, which aren't in the right. So that's an example of lymphoma involving the axilla or armpits. This is a cross-section through roughly the belly button. This is actually the belly button here. This is the left kidney, right kidney. This is the vertebrae, so this is the spine. So this is your back and this is your front, obviously. That's the aorta, so the main blood vessel that supplies blood to the bottom part of the leg. And this is a big para-aortic lymph node, and this is another lymph node over here. All of these loops of stuff over here are loops of bowel. It's the reason why they get you to drink the contrast so that the loops of bowel light up white to make them easier to eat, more easily distinguished from lymph glands. This is the same patient going back a little bit lower down, so it's now going through the pelvis, which is that white butterfly shaped thing, and all of this grey stuff around here, that's all, again, lymph glands further down around the aorta. This is the aorta as it's about to branch off into the arteries that go down into the legs. This is a PET scan. So this is a PET scan combined with a CT scan. That's the reason why there's 2 donuts. PET scan gives you a little bit more information in many circumstances than a CT scan does. It has less of a role to play in the slow-growing lymphomas. Certainly in the more aggressive lymphomas, like Hodgkin's and diffuse large cell lymphoma, PET scans are really important. We used to do a thing called a gallium scan in the old days, but we don't do those anymore. Basically what a PET scan involves, you get injected with a dye. It's a glucose dye. It has a radioisotope attached to it. So what happens, because it's glucose, it goes to anywhere in the body that is metabolically active. So anything that's eating sugar, that's where it goes to. And because it's got a little radio-labelled dye attached to it, they can then run you under a camera, which can then pick up the dye glowing. So this is an example of somebody who had bone lymphoma. So this is the brain. The kidneys down here, which collect up the dye and distribute it into the bladder. You can just get a faint shape of the heart in the background there, as well as the liver and the spleen. And the bowels also lighting up a little bit around there. All of these other discrete black circles are all individual deposits of lymphoma in the bone. So that's a very dramatic PET scan. A lot of those things you would not have been able to pick up on a CT scan. So there's an example of where a PET scan gave you so much more information. After treatment, this is what the PET scan looked like. So in fact, every one of those lesions resolved. So that's a really nice outcome. And you can more clearly see the outline again of the kidneys on each side, collecting up the dye and sending them down into the bladder. You can also see on this one the skeletons lighting up really intensely. So you can actually see each of the individual vertebrae and the long bones. That's because this person was on GCSF. So the medication we use to help the bone marrow recover quicker from the effects of chemo. So because the GCSF is really switching on the bone marrow, it means that the bone marrow becomes very metabolically active. I showed you the CT scan before, the person who had all those lymph glands down around the aorta. And this is what it looked like on the PET scan. So all of this stuff here was just a huge conglomeration of lymph glands down in the belly. Some up in the left side of the neck and under the left armpit. Now, we treated this person with 3 cycles of hypercvad, so a very aggressive protocol. And you can see that after that, there was some clearing, but there was still disease down here, some improvement in the left neck and the left armpit, but it hadn't all gone. So we changed tack on this particular person. We moved to a different type of chemo and then went ahead with a stem cell transplant using their own stem cells. And again, at the end of that, they were in complete remission on the PET scan. So it's an example of where the PET scan gave you a very firm idea about how you needed to treat that person. It wasn't going the way that we wanted to, and it's probably fairly similar to the way James looked at your scans after that sort of first little bit. That was actually, you can see here, so that was day 100 post-transplant. The period between this initial scan and actually getting to day 100 post-transplant was probably about 6 or 7 months. This particular person, we then did some CT scans for like about the 6-month mark and the 9-month mark. And I looked after, this was about 2009. That person's still in remission now. Lots of different lymph node groups. So this is one of the little guides that we use. So one of the problems with lymph glands is there's some that we can feel, the ones in the neck, the ones in the armpits, the ones in the groin. But there's all these lymph nodes that are buried very deep in that you can't get access to. So we're limited in terms of our examination skills about how much we can find. It's why we need to use the CT scans and PET scans to actually work out where everything is. So just to find a little bit to talk about, so how do we work out what treatment you need? Now obviously there's a lot of evidence out there for the more common diseases. For most circumstances, if you've got diffuse large cell lymphoma, you'll be treated with CHOP in combination with MAB-THERA. There might be some reasons why that has to change though. So we use scientific evidence. As I said before, we use the way that the disease is behaving to guide us. The more aggressive lymphomas need more aggressive treatment strategies. Other things, like if it's advanced stage, that often means that the outcome's not as good. Risk of the lymphoma getting to the brain or the spinal fluid, that also could change the treatment we use. But we also have to take into account the person who's there in front of us. The way that we might treat a lymphoma would be different for an 18-year-old, potentially to an 88-year-old. So it's not just about the disease, it's all about trying to do the best thing for that particular person and working out the best strategy for them. So different types of diseases, we use different prognostic scores. So one of the things that we do behind the scenes, and most of the time you should be given this information as well, we work out, based on certain characteristics of the lymphoma, what the overall prognosis is. So for example, in non-Hodgkin's lymphoma, particularly for the things like diffuse large cell lymphoma, there's 5 important factors we look at. Unfortunately, if you're older than 60, that counts against you. If you've got stage 3 or 4 disease, that counts against you. If you've got a high LDH, and LDH is a number that's measured on a blood test, that's a bad thing. If you've got more than one site of disease outside the lymph glands, that's also not so good. And if for whatever reason your ability to function as a normal human being has been compromised, that might be due to other medical illnesses. It might also be due to the lymphoma. Then that also counts against you. And basically, you look at these 5 factors and work out a score. So basically, if you've got 0 or 1 factor, you're in a low-risk group. If you've got 4 or 5, you're in a high-risk group. And ultimately, that then determines the prognosis. So this is the overall survival. So what the expectation of being alive at 5 years is, back in the days before MAB-Thera. So even if you had the low-risk group, your probability of survival at 5 years was only 73%. So only 3/4 of people were still alive. If you're in the bad risk disease, only 1 in 4 people were still alive. And that was mainly because of relapse, so the disease coming back. And you can see what a massive difference MAB-Thera has made. Now, this is 4-year mark, so it's a year earlier than the old data. But so if you're in the low risk group, you now have somewhere between an 80 to 95% chance of being alive at 5 years. Even if you're in the bad risk group, we've doubled the probability that you'll be alive and in remission. So 55% still not great odds, but clearly it's much better than 26%. So you could probably say on the whole, for this group here, we're doing quite well. I suppose if it's less than 100, then we're not quite there yet. But we've made substantial gains here. But there might be an argument for people in this group that maybe we need to do something different for their treatment. Maybe the CHOP MAB-Thera is not necessarily the right thing for them. It's still probably what we would do, but it remains a group who we need to work a little bit harder on. For the follicular lymphoma, we talk about the Flippy score. So again, it's 5 factors. There's a couple in common, so age, stage and LDH remain important. But we're now talking about things like the haemoglobin and how many of those lymph node groups are actually involved. So because follicular lymphoma often involves multiple groups, it's actually 4 or more is bad. And if you're anemic when you first turn up, that's important. And again, we plug that into our prognostic score. Because it's a slower growing disease, we're now talking about 10-year survival, not 5-year survival. So if you've got 0 to 1 risk factors, it's 71%. 3 plus, it's 36%. So again, if you happen to fall in this particular group here, it's one of those things maybe we need to intensify or do something a bit different of the treatment to actually try to sort of move you up into this sort of group. For Hodgkin's, so this is, it was Professor Hasenclever from Germany who published this score. And this is for people with advanced stage Hodgkin's, so for people who have greater than stage 2A disease when they first turn up. So a lot of it's based on blood test results, so things like the albumin, which is one of the proteins in the blood, your haemoglobin or red cell count, white cell count and lymphocyte count. Age, so again 45 and above, you know, for the non-Hodgkin's lymphoma is 60 and above. Hodgkin's tends to be a younger person's disease, so because of that the average age is lower, so that's the reason probably why the average age in this thing in terms of what's bad was 45 and above. Stage 4, so not 3 or 4, it's just stage 4. And gender, for some reason men with Hodgkin's have an inferior outcome to women, not known why. And again, we look at those 7 risk factors and essentially divide it again up on the number that are involved. So once more, like we were talking about with the non-Hodgkin's, if you've got 0 risk factors, you've got a reasonable chance of doing very well. Whereas for the group down here, you've got a less than 50% chance of you know, being alive. Now that's with standard treatment with ABVD. And so that's where, for example, things like beer cop may come into importance, is where clearly the standard treatment doesn't look very good. Might be a circumstance where we need to think about more intensive treatment. And so just as a couple of cases to finish on. So a relatively young gentleman was diagnosed with diffuse large B-cell lymphoma. He had all of his CTs and PET scans done, and it showed that he had multiple different lymph glands, both sides of the diaphragm, so he's got at least stage 3 disease. But in addition, he also had a lump of lymphoma next to his vertebrae, which was actually encroaching then through the little holes into the spinal fluid and near the spinal cord. So because of that, because it's involving the central nervous system, you become stage 4 disease automatically. He didn't have fever, sweats or weight loss, so he's not a B, he's an A, so he was stage 4A. When we did that IPI score, he had 3 out of the 5 risk factors, and that means he was in the intermediate or high intermediate risk group. Now, as I said, the standard of treatment would be CHOP MAD-THERA, but in fact we chose something different for this fellow. First of all, he's young, so therefore he's more likely to be able to tolerate more intensive treatment, and we were very worried about the fact that this mass was encroaching into his central nervous system. So we felt he needed a type of chemo protocol that would actually get into his brain and spinal fluid to make sure that that was treated, and also to guard against the possibility of him relapsing in the future. So hyper-CVAD again is a leukemia style of protocol which covers that central nervous system very well. So it's the reason why in this particular case we chose a more intensive protocol. On the flip side, a 32-year-old lady who gets diagnosed with Hodgkin's lymphoma. Similar sort of scenario, so multiple 2 to 3 centimetre lymph glands on both sides of the diaphragm again, so becomes stage 3 disease. Bone marrow wasn't involved, there was no disease outside the lymph glands, so it becomes stage 3. And again, no B symptoms, so stage 3A. Now, when we did that Hazen-Clever score, there was 0 of 7 risk factors involved. As I said, if she was a boy, then in fact there would have been 1 automatically as a consequence. So if we go back to the slide prognosis, this person has about an 85% chance of being alive and in remission in 5 years' time. And so because it's advanced stage, we had to have a think as a group. We have lymphoma meetings where we sit down and talk about all of our patients. And the question was, should we go for ABVD or should we consider the more intensive protocol, BIACOP? And because this person had no adverse risk factors, we chose the more standard of treatment for them. And again, they actually went very well and remain alive in remission now at about 7 years down the track. So there's one example of somebody with a reasonably similar presentation who ended up using really aggressive treatment strategy, but in the other person, we ended up doing the standard of care because we felt that was the best thing for them. Yeah, look, I've seen no consistent evidence that diet or complementary medicines or anything like that make a difference to outcome. The only thing I would say is that I think having the best nutrition that you can through the treatment speeds up the recovery from that treatment. Again, you know, if you can sort of keep weight on, keep muscle strength, and it can be really, you know, in many cases impossible to do that despite your best efforts, then that's important for the recovery time. But as I say, you know, there's been a lot of research looking into, you know, do sugars feed cancers? Do sugars feed lymphomas? You see some data suggesting they might do, others showing it's not true. So my general advice, based on what we know at the moment, is have the best, the healthiest diet that you can have, you know, during the treatment. Having said that, I actually think sometimes having really high energy stuff is probably quite important. So it's almost reasonable to forsake the National Heart Foundation tick-approved diet for a period of time and actually have stuff that's relatively high energy, because your metabolic rate is so fast most of the time during the treatment that people lose weight because they're burning up so much stuff as their body goes through the recovery phase. So I think having stuff that's relatively high in energy may actually be better for you. But those things actually probably do give you the best energy during that time. So as I say, you know, I always say to people, you know, well-balanced, healthy diet, exercise as you can. You know, I mean, I think exercise gives you a positive lift and a positive outlook. You know, they're probably the 3 things that you can actually do for yourself to remain in control as best as you can. You know, a lot of the other things that you can control are being removed from you because you're going through chemo, you're getting complications despite your best efforts. So it's those sort of things that you can actually do something about. But look, I don't think you can get too scientific about it because there isn't convincing evidence. And you get a lot of stuff out there in the mainstream media, which is like a really small study performed in some out-of-the-way part of the world, and it's put up there as being the, this is the answer, and it rarely is. There's often sort of 22 other papers that suggest that that paper was completely wrong. So, as I say, I don't think you want to go fiddling too much. Again, your taste buds change, what you enjoy changes, so eat lots of what you enjoy and forget about the other stuff. It will fix itself later. Yeah, well, as I said, age greater than 60 on those studies. And it's all, the way these things are done is they take a large sample of patients with lymphomas, often several thousand. They plug in all of those patients' blood test results, their staging results, all that kind of thing, and they do what's called a multivariate analysis. So basically the computer does this statistical test, and it spits out at the end of that what the important factors were that determined people's outcome. So it's very scientific, and we use it in day-to-day practice, but there's we don't just rely on that number. Large B is one of the aggressive ones, but it's not regarded in the highly aggressive group. I mean, the highly aggressive group behave like leukemias, and they're relatively uncommon.
Can it go from B cell to become a T cell?
Very rarely, but it's not unheard of, yeah. Some people will have both diseases coexisting, so completely separate T cell and B cell lymphomas.
And the other thing is,
yep.
Has anything progressed with that as yet?
For lymphomas, I don't know about. Certainly for leukemia, there is a fairly well-established tissue bank, but it would have been something that you would have had to have given consent for storage anyway. So if you gave consent for storage, I mean, again, the pathologist actually will maintain your samples and the slides and all that sort of thing for many, many years, so they don't completely ever discard them. Most often not, yeah. So more often than not, particularly say with the lower grade lymphomas, your blood test can be completely normal. Yeah, yeah. So, I always say, like, in terms of the follow-up, basically 85% of important information is what you tell us. So it's based on that history when we say, how have you been, all that sort of thing. 10% is based on the examination. So most of the time, we're not going to pick too much up if you're really well, because it means nothing's there. And only 5% is based on the blood test. So the blood tests are a small part of it. They are part of it, and it means you can't get away without having the blood test. But most of the time, something that you tell us is the most critical thing that alerts us of the possibility of the lymphoma being back. And that's it for me.